Let's begin our coverage of chapters 13 and 14. Chapter 13 is the schizophrenia spectrum disorders and other related conditions, and chapter 14 is the conditions treatment. Most textbooks have this as one single chapter, so we're going to treat it as one single chapter too. Please note the use of the word or rather phrase schizophrenia spectrum in lieu of schizophrenia. DSM-5 changed it from being schizophrenia to schizophrenia spectrum, so we will also use this terminology. So the schizophrenia spectrum disorders are a family of psychotic disorders, and they are not related to multiple personality disorder, which is a dissociative disorder. So different in cause, symptoms, and treatments. Now you'll notice that I use the word psychotic, which is related to the word psychoses. Psychoses refers to a lack of contact or a loss of contact with reality, such as a person being delusional and or hallucinating. In schizophrenia, when the person is in active mode, poor insight is typical. They don't see their behaviors as other people see them. Schizophrenia spectrum affects about 1% of the population, and yet counts for a disproportionate number of suicides within the mentally ill population. Indeed, 20% of people with schizophrenia will attempt suicide. As you can see from the slide, there's a differential age of onset by sex. Men, on average, begin their first symptoms of schizophrenia at age 18. For women, slightly later, at age 25. For a diagnosis of schizophrenia spectrum to be correct, the symptoms must be present for 6 months or longer. It appears to be related to an excess of one particular neurotransmitter. Think about the neurotransmitters for a moment and see if you can remember which one. As a hint, it's also associated with Parkinson's. If you're thinking dopamine, you were correct. Before 1950, a diagnosis of schizophrenia in all likelihood meant lifetime hospitalization. But nowadays, not at all the case. Drug treatments only were available since about 1950. Currently, there are 2 families of medications we'll discuss later in this chapter. So nowadays, a person with schizophrenia can expect to live a full life with all the same achievements and probably difficulties as other people. Let's consider the diagnostic criteria for schizophrenia spectrum disorder. Hallucinations, delusions, disorganized speech, which means it's either very incoherent, or derailing, which means constantly getting off subject, not being able to follow a single line of thought. Grossly abnormal behavior, which can be disorganized, which can mean erratic all over the place, or silly and childlike, or catatonic, which would refer to being frozen, statue-like, often in very odd positions. Also negative symptoms. This refers to behaviors that are expected that are missing. And we'll have a slide explain this further. Before you go on, please click the first link. You'll see a person that's hospitalized with severe schizophrenia. This is an older but commonly used video. I hope for his sake that when the second family of medications became available in 1998 that he was helped. The second one will probably surprise you. It's a simulation which gives you a little bit of an idea of what it could be like to be actively schizophrenic. Let's consider delusions. We'll define delusion as a firmly held, clearly false belief. There are common delusions. The most common type would be the paranoid or persecutory type. thinking people are out to get you, the government's out to get you, librarians are out to get you, people are sabotaging your work, people are sabotaging your life. Most common, again, the most common type. Grandeur would be that you have godlike abilities, that you can perhaps control the weather, control global warming. Also delusions of thought control. You believe others are controlling your thoughts, that you are not able to think as you freely wish. Others are directly altering your thinking. Another one would be thought broadcasting, the belief that your thoughts are being broadcast, kind of like a radio tower, and they're often very distressed about what's happening to the thoughts. Maybe they're ending up in a marquee in a theater, maybe they're being texted or tweeted, or they're appearing on TV screens or being sent in mass mail. So thought broadcasting is another common theme. Reference refers to thinking that common events in the world directly and personally relate to you. So if a bridge is out, it's because they wanted you to be late, because they are threatened by your intellect. If a bulletin board has something scrawled on it, it's specifically for you and no one else. So everything in the world relates specifically to you. Last one, thought withdrawal, kind of like the opposite of thought control. This is where thoughts are being removed from your brain, stolen. So again, a person with a schizophrenia spectrum often has one or more, and typically more, delusion types. Let's consider negative symptoms. These are features that are expected that are missing from the person that's actively schizophrenic. So they're deficits. So motivation, the person's fully unmotivated, maybe barely gets off the couch. Deficits in emotions, we often use the term flat emotions, no highs, no lows, basically emotionless. Deficits in interaction, initiating very few interactions, not responding when others interact with you. Deficits in speech, maybe no speech at all or very, very minimal speech. Or it could be deficits in movement. Picture below is catatonia, a person frozen in an odd, typically position, clearly a deficit in movement. What is the typical progression of schizophrenia? It has three phases, so you can see prodromal, active, and residual. The prodromal phase is the before stage. You'll see features that are not necessarily specific to schizophrenia. Social withdrawal, odd behavior, speech and emotions. Now that's getting closer to being schizophrenia specific. Poor communication, rather general, and grooming neglect, also fairly general, often seen in depression. The active phase, full-blown symptoms of schizophrenia. In the residual phase, the symptoms are largely gone, but usually not 100% gone. 100% recovery is rare, but again, people with this disorder can lead very productive lives, so things are not off the table. Work, family, job. But it does require the person to be medication compliant, and for many people, that is a significant issue. So in Chapter 15, our focus is schizophrenia spectrum and other related psychotic disorders. We'll consider first brief psychotic disorder. You might ask, well, how brief is brief? The symptoms have to be present at least for one full day, at least for 24 hours, but less than 1 month. If it lasts longer than 1 month, then this diagnosis is no longer appropriate. As part of the definition, the person must return to their normal functioning, and it gets a little bit fuzzy here. The person may return to normal functioning because they're on antipsychotic medications, but it would still count as brief psychotic disorder. If the person does not return to normal functioning, then we'll use other terms and it would be another psychotic related disorder. According to the DSM, the diagnosis of brief psychotic disorder is difficult, and the term provisional should be used if the person is within that 1 month. So week 1, week 2, week 3, the term provisional should be used if the diagnosis of brief psychotic disorder must be used. It might need to be used for insurance purposes. It would be best not to put that term into record until that point, but sometimes it's necessary. Next, we'll consider schizophreniform, schizoid personality disorder, schizotypal personality disorder, schizoaffective disorder, and delusional disorder. So perhaps you're wondering that what if a person with brief psychotic disorder, maybe with a provisional diagnosis, has met a month, or a month and a day, or a month and 2 days, and so on? Well, what diagnosis is appropriate? At that point, the term used would be schizophreniform disorder. Schizophreniform disorder diagnosis is appropriate when the symptoms have been present for at least 1 month, but under 6 months, because at 6 months then the diagnosis of schizophrenia is appropriate. Again, if a diagnosis of schizophreniform disorder must be made, the term provisional should be used because it's not clear at 1 month, at 2 months, at 3 months, and so on, if the person will still have symptoms at 6 months. And again, symptoms for 6 months is needed for the diagnosis of schizophrenia spectrum. Next, we'll consider 2 personality disorders related to schizophrenia. Often a person with schizophrenia would have a person in the family with one of these 2 disorders, though quite possibly undiagnosed. A person with these personality disorders also has increased risk of schizophrenia. For the first one, schizoid, the key feature is social issues, isolation, and this isolation is due to preference. They have a lack of interest in other people. They have lack of interest in small talk. They may have no best friends, or their best friend keeps the relationship going. They will typically not have a significant other unless somebody makes a lot of effort and maybe they agree to this relationship, but the relationship would not be prized, would not be valued. They're just in it because the other person is doing the work. With schizotypal, or sometimes pronounced schizotypal, this person is odd, eccentric, but the degree of oddness and eccentricity doesn't rise to the level of disorganized behavior. Let's now consider schizoaffective disorder. Now, see if you can remember what the term affect means. It'll help you know what this disorder is focused on. So we learned that affect refers to emotion, mood. So this person meets the criteria for schizophrenia and will also at that point or another point meet the criteria for either major depression or bipolar disorder. So it's like a dual diagnosis. They do not have to have both conditions at the same time, but they need a diagnosis of schizophrenia at some point, and again a diagnosis of one of those 2 mood disorders just mentioned at a point. Lastly, let's consider delusional disorder. The key feature of delusional disorder is obviously delusions. They can be either realistic things that could be within the realm of possibility, or they could be bizarre. But the person will not have any other features of schizophrenia. So no hallucinations, no disorganized behavior, no emotional issues, and so on. So the focus for this particular disorder would be the presence of delusions. Now let's consider the etiology, a fancy word for causes, or at least possible causes, of schizophrenia. A major accepted explanation is the dopamine hypothesis, saying that schizophrenia results, or at least strongly relates, to an excess of brain dopamine. Use of drugs like cocaine, amphetamines, alcohol, and especially cannabis increase risk in those that have a genetic vulnerability. There's also the diathesis stress model. The term diathesis means a pre-existing vulnerability, for example, carrying the genetics for schizophrenia. When combined with stressors, such as maybe first-time college, the loss of a job or parent, moving, deployment, war, etc., would result quite possibly in mental illness. So it's saying that stressors alone is insufficient, the diathesis alone is insufficient, but when combined, that would greatly increase the probability of mental illness. We know that there are at least 20 specific genes involved in schizophrenia. One has a 20% risk if one parent has the disorder, so clearly it's more than genetic, so this diathesis stress model is particularly satisfying. Another perspective is expressed emotion. Again, it would assume that the person carries the genetics, but it believes and states that family communication style can be a contributor. So family styles of communication that are contradictory, highly cold, highly critical, are associated with a higher relapse rate. And some research would suggest a higher incidence of schizophrenia itself. Let's consider treatment of the past. In ancient times, we have trepanning and exorcism. As you might remember from earlier chapter, trepanning is when the person, without the benefit of anesthesia, would have their scalp incised, a circular piece of skull removed, and the injury sutured back up. The brain was never touched, the meninges were never touched. That would have been lethal. And we presume that these skulls that we found throughout the world were people that suffered from schizophrenia. It's likely that after this treatment, not only did they have schizophrenia, but also PTSD. No cultures currently perform trepanning. Exorcism, on the other hand, as we learned, are rituals designed to drive out the inhabiting supernatural force, to make the body physically uncomfortable, which could be starvation, whipping, flogging, immersion in icy water, forced vomiting. And as we learned, some and even many cultures do believe and practice exorcism. It can actually be even performed with special discompensation from the Catholic Church. Obviously, your HMO will not pay for an exorcism. From the time of the late 1700s through the advent of psychiatric drugs, warehousing was practiced in the U.S. People were basically locked in facilities like the one shown on the right. No treatment was available. Sometimes the conditions were pleasant, often they were indescribably unpleasant. The person would often spend their lifetime in the institution and would often be buried in the institutional cemetery. During this time period, at least in the 20th century, the earliest 20th century, insulin shock therapy was also practiced, altering blood insulin levels to throw the body into shock with the idea of resetting the brain. This obviously was not effective. Next, let's consider lobotomies. So the lobotomy was a procedure that was slowly phased out with the advent of psychiatric drugs. So it wasn't a one day doing it and one day not doing it, but it slowly phased out, getting to the point that lobotomies are no longer done. In fact, the last lobotomy is done in the 1960s. Are you aware of any famous movies on the topic of lobotomy? The next slide will give you an answer. Hijas Moniz received for his lobotomy procedure both the Nobel Prize and being shot by one of his rather unhappy patients, resulting in paralysis. Definitely a mixed review. The picture below is that of the celebrated neurologist and lobotomy zealot, Walter Friedman. Now, from its advent, about 50,000 lobotomies were performed in the U.S. 3,500 of them were performed by Walter Friedman, the so-called ice pick lobotomy. Friedman, as I mentioned, very zealous in his dedication to the technique, performed as many as 20 per day. Now, the last lobotomy in the U.S. was performed in 1967 by Friedman. The patient died on the table, and as a result, he did lose his medical license. But that was not the first death that Friedman experienced. 490 of his patients also died, approximately 1 in 15. Most did survive, though, but at best, he indicated they lost the sparkle, aspects of their personality, zest. More catastrophic outcomes also occurred, such as severe intellectual loss, paralysis, epilepsy, inability to control one's bowel or bladder. So thank goodness the procedure was phased out, but again, not by any action done by, at least any intentional action done by Friedman. One Flew Over the Cuckoo's Nest with a very young Jack Nicholson was focused on the topic of lobotomy. Let's assess our studying. After you've sufficiently reviewed the content, please see if you can match the disorder with its description. Those that give you trouble, go back and study and then repeat the process, and definitely do this once or twice till you're successful immediately prior to taking the test on this content. So for a diagnosis of schizophrenia and a mood disorder, since we know the word affect means mood, this would be schizoaffective disorder. Hopefully that was an easier one. Diagnosis of schizophrenia or symptoms of schizophrenia for less than 1 month, that would be brief psychotic disorder. Total disinterest in people with no other features, that would be schizoid personality disorder. Bizarre or non-bizarre, clearly false beliefs with no other symptoms. So that's talking about delusions, so that would be delusional disorder. Odd and eccentric behaviors and thoughts without other symptoms, well, that would be schizotypal personality disorder. And symptoms of schizophrenia for more than 1 month, but less than the required 6 months for a schizophrenia spectrum diagnosis, that would be schizophreniform disorder. So again, repeat studying for the ones that gave you any trouble, and perhaps none gave you trouble. If so, great.